Hello everyone. Yes, our mission is FMG. Yes, 150. We try to do at least 150 question from these pediatrics lectures. Yes, one we have discussed yesterday. Pediatric part 2 is today. I am your pediatric educator, Dr. Sanjay Khatri on YouTube channel Unacademy. So, something about Unacademy. NEET PG notes 2.0. Get early bid access. Valid till 6th July. If you want to take it for 9 months, see the price. If 12 months, see the price. What you are waiting for, friends? Go for it. Now, NEET PG Vitals. Recorded video for comprehensive NEET PG preparation. Just join and feel the difference. All the top educators with their good experience along with the technical team of Unacademy provide you the best of best videos. Okay, for all 19 subjects. Now, NEET PG MD scholarship test. My personal view. Why to miss these tests? Nothing to lose. Compare your rank amongst the other and prize to win. So note down the date, 9th July, 11 a.m. Enroll for free. Now, without wasting any more time, come to the FMG question. Yesterday, we covered general pediatrics question, basic pediatrics question. Namaste, hello everyone. Namaste, hello everyone. General pediatrics question, milestone, vaccine, syndromes, metabolic disorder, we covered yesterday. Some key question. Today is the term of systemic pediatrics. Trust me, key question of cardiovascular system, hematology, platelet disorder, nephrology, neurology, respiratory, GIT, diarrhea, we discuss here. Be there, enjoy the class. Earliest response to iron therapy in iron deficiency anemia is earliest response to iron therapy in iron deficiency anemia is iron deficiency anemia and you started iron. What is the earliest response in the body? If you know this, which we have discussed in the class so many times, and this question comes 4 times in UPSC exam. So this question is there in their board, their question bank. It may come in FMG also. So if you know, it's very easy. If you don't know, most of the people put C, reticulocytosis, but this is not the correct answer. Now, once you start iron, in 12 to 24 hours, earliest change is replacement of intracellular iron enzymes. What are the intracellular iron enzymes? MAO, peroxidase, catalase. These are the iron containing enzyme. First of all, their level comes to normal. Then subjective improvement in the form of decreased irritability, increased appetite. Decrease irritability, increase appetite. If somebody comes, parents comes to us, बच्चे को भूख नहीं लगती है, decrease appetite. The earliest thing pediatrician start iron because it increase the appetite, it decrease the irritability. So this is the earliest change. Then 36 to 48 hour bone marrow response, erythroid hyperplasia. Then 48 to 72 hour reticulocytosis occur. So when reticulocytosis occur? On third day, 48 to 72 hour. When hemoglobin begin to increase? Fourth day onward. And we continue iron therapy for 3 months because we want to replenish the store. Once you are giving the iron, prescribe it for at least 3 months to correct the anemia. So this is the MCQ. Earliest response, replacement of intracellular enzyme. Suppose this is not in the choice, then you can write subjective improvement. In form of decreased irritability, increased appetite, reticulocytosis, third day. Hemoglobin begin to increase, fourth day onward. So remember this, earliest response to iron therapy in iron deficiency anemia. Answer this. 10-year-old boy presented with gross hematuria, significant dysmorphic RBC. 2 days after the attack of upper respiratory infection. I bet you this and related question almost every year in FMG exam. Almost every year. Now see, patient develop URI, then develop hematuria. Why hematuria? Due to glomerulonephritis. Now, the key, after how many days of URI patient develop hematuria? If hematuria occur after 2 days of URI, then answer will be IgA nephropathy. If hematuria occur 2 weeks after URI, then answer would be post-streptococcal glomerulonephritis. Oh, so most of you make it wrong. So correct answer is IgA nephropathy. Yes, Yusuf, Pragya Singh, Yusuf, you put it right. So here it's 2 days. 2 days. So it is IgA nephropathy, Berger's disease. If it occur after 2 weeks, then it is post-streptococcal glomerulonephritis. So read the question carefully. This is one of the sure and short question in the exam. Either this or this. Read this. A 7-year-old boy, sore throat, 2 weeks back. Now manifest with periorbital edema. Urine is Coca-Cola colored. Why urine is Coca-Cola colored? RBC in urine. After 2 weeks of throat infection, serum complement level is low. Classical. It is post-streptococcal glomerulonephritis. My friend, it's my sincere request. Remember these two questions. After URI, hematuria. If occur after 2 days, IgA nephropathy. If 2 weeks, post-streptococcal glomerulonephritis. And post-streptococcal nephritis, complement level is low. C3 normal level is 100. But in post-streptococcal glomerulonephritis, you find it 15 milligram per DL. So C3 is low. C3 is low. After sore throat, 2 week hematuria is there. So be remember these type of 2 questions. Trust me, with my experience, yes, this is in your exam. Answer this. Answer this. 15-year-old female present with history of dyspnea on exertion. Slowly. Examination, she has a wide and fixed splitting of second heart sound. No, it can occur in children also, Berger's disease. So 15-year, second heart sound, wide and fixed split. Just concentrate on this. If second heart sound, wide and fixed is split. Second heart sound, wide and fixed split. Just ask yourself, is there is cyanosis? Yes. Then only one answer in universe. Second heart sound, wide and fixed in cyanotic baby. It is TAPVC. No, there is no cyanosis. Then it has to be ASD. So in question, cyanosis word is not given. Not given, na? Cyanosis is not given. History of dyspnea on exertion given. So it can't be TAPVC. It can't be tricuspid atresia because these two are cyanotic CHD. It has to be ASD, but which ASD? You got it? See the approach. Second heart sound, wide and fixed split. Look for cyanosis. Is there? It is TAPVC. Cyanosis not there. It has to be ASD. Look at the ECG. If ECG show left axis deviation, It is ostium primum ASD. ECG show right axis deviation. It is ostium secundum ASD. Go to the question again. ECG shows left axis deviation. Second ultrasound wide and fixed plate, no cyanosis. ECG show left axis deviation. So your answer would be ostium primum ASD. Your answer would be ostium primum ASD. Am I clear? If clear, give me a thumbs up. Cyanosis is there with second ultrasound wide and fixed plate. So it is TAPVC. If no cyanosis, look at, it is ASD, but which ASD? Look at the ECG finding. If there is left axis deviation, it is ostium primum ASD. If it is right axis deviation, it is ostium secundum ASD. Yeah, Pragya. So it's clear? Clear? Now remember two good, very good 2 points in CHD. Point number 1. Put answer in the comment box. It's cyanotic CHD. Cyanotic CHD with decreased pulmonary blood flow. Means child become more blue when child is crying. Cyanotic CHD, decreased pulmonary blood flow. ECG show left axis deviation. What is the answer? Please reply in the comment box. Cyanotic child, decreased pulmonary blood flow, and ECG show left axis deviation. What is the answer? Very good, Yusuf. Maja aa gaya. Answer it. Tricuspid atresia. Tricuspid atresia. Trust me, this question so many times asked in the NEET PG, I can say expire ho gaya. They will not ask now. Cyanotic CHD, decreased pulmonary blood flow, left axis deviation. It's tricuspid atresia. Second one to guess you. Cyanotic CHD, increased pulmonary blood flow. Second ultrasound, wide and fixed plate. Cyanotic CHD, cyanotic CHD, cyanotic CHD. So answer would be TAPVC. Answer would be TAPVC. These two beautiful points. Remember, I know most of you know this. Just to hammer again. Cyanotic CHD, decreased pulmonary blood flow, left axis deviation, tricuspid atresia. Cyanotic CHD, increased pulmonary blood flow, second ultrasound wide and fixed plate. It is TAPVC. Move. Answer. Read this question. Last to last year FMG question. A 6-year-old has recurrent episode of blinking fast and then continuously staring. Usually these episodes last for 30 seconds with abrupt termination. Their poor performance at school. Which of the following should be started? What is this? What is this? All of you know the answer. But what is this? Very good, Rafiq. Khan Saab. Yes, it is absent seizure. Drug of choice is sodium valproate. What is absent seizure? Absent seizure. Sudden cessation of motor activity with blank facial look. You are writing, suddenly blank. This is absent seizure. Sudden cessation of motor activity with blank facial look. More common in girls. More common in girls. Rarely last for more than 30 seconds. Rarely occur below 5 years. Rarely last below 30 seconds. Rarely occur below 5 years. Multiple episode in a single day. Very good. No aura, no post-ictal drowsiness. No aura, no post-ictal drowsiness. Hyperventilation precede the attack. EEG show 2-3 spike per second. These all are MCQs. These all are MCQ. 9 points of absent seizure. All are true at absent seizure except More common in boys? No, more common in girls. Lasts for 2 minutes? No, rarely lasts for more than 30 seconds. EG show domain spike pattern? No, EG show 3 spike per second pattern. Which seizure is preceded by hyperventilation? Absence seizure. And drug of choice of absence seizure is sodium valproate. First line ethosuxamide, yes, but first line sodium valproate. Because sodium valproate we can avoid below 3 years, but absence seizure is rarely before 5 years. So yes, number one, drug of choice sodium valproate. But if absence seizure occur in 3-4 years, you can avoid sodium valproate, give ethosuxamide. But drug of choice is sodium valproate. Answer this question. Just a basic question about murmur, pulse. Yes, I will cover so many questions on murmur. I want answer from your side. Which of the following is continuous murmur? Astrin fluent is a diastolic murmur. Gram steel is a diastolic murmur. Doc is a diastolic murmur. Gibson murmur is a continuous murmur. You need to remember with name. Astrin-fluent murmur present in aortic regurgitation. Gram steel murmur in pulmonary regurgitation with pulmonary hypertension. Dox murmur, D for D, present in LAD stenosis. Gibson murmur, it's a continuous murmur present in PD. Very simple. Just it will take 1 minute. Revise all the murmurs with name. Astrin-fluent murmur, it's a diastolic murmur. Roser murmur, it's a systolic murmur. Carrie-Q murmur, again it's a diastolic murmur. Dox murmur, again it's a diastolic murmur. Gibson murmur, it's a continuous murmur. Gram steel murmur, it's a diastolic murmur. Still murmur is a systolic murmur. Ratidinous murmur is a diastolic murmur. Very simple. Summary. All murmurs with name is diastolic. Gibson, you remember, it's a continuous murmur. Roser murmur is present in VSD. So you can remember VSD murmur is a systolic murmur, and still functional murmur, S for still, S for systole, it is present. It's a systolic murmur. Rest all are diastolic. So just remember still systolic, Roser systolic, and Gibson continuous. That's all are diastolic murmur. Astrin-fluent murmur present in aortic regurgitation. Roser murmur present in VSD. Carrie-Q murmur present in rheumatic fever. Dox murmur present in LAD stenosis. Gibson murmur present in PDA. Gram steel murmur present in pulmonary regurgitation with pulmonary hypertension. Still murmur, it's a functional murmur without any defect. Soft murmur is there, which may be due to thin chest, which may be due to hyperdynamic circulation, which may be due to severe anemia. Still murmur, functional murmur. And ratidinous murmur, complete heart block. So remember, these are the things, my friend. You are going for exam. It's a very simple. They will ask you Astrin-fluent murmur present in aortic regurgitation. Still murmur is systolic murmur. Carrie-Q murmur present in rheumatic fever. It takes 30 seconds. Revise. 30 seconds. Astrin-fluent murmur, aortic regurgitation. Roser murmur, VSD. Carrie-Q murmur, rheumatic fever. Dox murmur, D, LAD stenosis. Gibson murmur, PDA. Gram steel murmur, PR, pulmonary regurgitation. Still murmur, functional. Ratidinous murmur, complete heart block. Clear? Move. Answer this question. Don't afraid with long question. History based question. You just read this, answer is there. You read this question, answer is there with you. 1 month present pediatric OPD. Temperature normal, pulse 130, pressure, blood pressure 72/32, respiratory rate 28. She is acyanotic. Means history based question, but first three line they waste to build the history. Always concentrate on last two line. Bounding pulse and 3/6 continuous murmur at left infraclavicular region. Only one answer in universe, that is PD. And I will ask, what is the name of PDA murmur? It's Gibson murmur. So summary, don't afraid with long questions. Just concentrate on last 2-3 lines where the key points are written. First 2-3 lines, sometimes they give to build the question. A baby delivered by this, vitals are this, then positive finding in last two line. It's Gibson disease. Suppose examiner want ASD should be the answer. Then examiner write the classical finding of ASD. What is the classical finding of ASD? Second, heart sound, wide and fixed split. If aortic stenosis is the answer, then examiner will give in the question ejection click present, ejection systolic murmur relating to carotids. If VSD is the answer, then examiner will write pant systolic murmur present. Then only you can answer, na? If examiner given the question continuous murmur, our answer is PDA. If examiner put on examination, you had a panstolic murmur, then answer is VSD. On examination, you had a ejection click murmur related to carotid, then answer would be aortic stenosis. Suppose same question, when you examine the child, femoral is not palpable. When femoral is not palpable, what is the answer? Coarctation of aorta. Like this, never afraid with history based question. Remember the classical point of every CHD, you will get the answer. Cyanotic, tricuspid atresia, TAPVC, commonly question asked. Acyanotic, ASD, VSD, AS, PDA, common finding you know, question will be yours. Answer. So simple. No, we can't answer such simple questions. We are preparing for FMG. It's a simple question. Since we enter into MBBS, we are reading macrocytic anemia. But frankly speaking, we are not clear in the concepts. So remember now, macrocytic hypochromic anemia on the basis of MCV. If less than 80, microcytic. More than 100, macrocytic. MCV is normal between 80 to 100. These four causes of macrocytic anemia we always remember. We always remember these four causes. Iron deficiency anemia, anemia of chronic disease, thalassemia, sideroblastic anemia. Four causes of macrocytic we always remember. B12 deficiency, folic acid deficiency, liver disease, hypothyroidism, and drugs like jiduvidine, cotrimexazole. But today we need to remember more for MCQs. Copper deficiency, macrocytic anemia. Pyridoxine deficiency, macrocytic anemia. This will give you definitely MCQ. Thiamine deficiency, macrocytic. Leschnian syndrome, macrocytic. And one more, orotic aciduria, macrocytic anemia. So remember my friend, today, four macrocytic we always remember. Iron deficiency anemia, anemia of chronic disease, thalassemia, sideroblastic anemia. Two are copper deficiency, pyridoxine deficiency. Good day, greeting, Rishi. Okay. So see the question. All are the causes of microcytic hypochromic anemia. Copper deficiency? Yes. Pyridoxine deficiency? Yes. Sideroblastic anemia? Yes. Thiamine deficiency? No. You have macrocytic anemia. Other than thiamine, you have in Lesch, Nihan, syndrome and orotic acid urea. You have macrocytic anemia. Trust me, remember these points. Trust me. So thiamine deficiency, macrocytic. Copper deficiency, pyridoxine deficiency, microcytic. Answer this. Answer this question. A child died soon after birth. There is hepatomegaly, splenomegaly, edema all over body, anasarca. So child develop hydrops. So what are the possibility? No, I am not getting the correct answer. Madhan is okay. It's alpha thalassemia. Alpha thalassemia. ABO incompatibility. No chance. Child died soon after birth. Beta thalassemia manifest by 3 to 9 months. Hereditary spherocytosis, at least very severe, to leads child died soon after birth. It is alpha thalassemia. Why? Alpha thalassemia. Alpha to beta 2. If alpha chain is not forming, this is alpha thalassemia. Now what happen if alpha chain is not forming? Sometime 4 beta form, sometime 4 gamma form. If 4 gamma form, this is known as Bart hemoglobin. Bart hemoglobin has gamma 4 is Bart hemoglobin. Bart hemoglobin has high affinity for oxygen. It not delivered oxygen at tissue level. Not delivered oxygen at tissue level. So what happened? What happened? Cell death. Cell death. Hydrops. Child died soon after birth. Yes, alpha thalassemia due to Bart hemoglobin. Bart hemoglobin. Now see here. You should remember all these type of hemoglobin. Question may come. Goer 1, epsilon 2, zeta 2. Goer 2, epsilon 2, alpha 2. Portland, zeta 2, gamma 2. Bart hemoglobin, gamma 4. Hemoglobin H, beta 4. You should remember at least Goer 1. Both chains are new. Epsilon 2, zeta 2 is Goer 1. Bart hemoglobin, gamma 4. Hemoglobin H, beta 4. Bart hemoglobin and hemoglobin H present in alpha thalassemia. These three are embryonic hemoglobin. Present in fetus, disappear. They will not present in a normal baby. Goer 1, Goer 2, Portland, Bart and hemoglobin H. You need to remember. Need to remember. Something you remember, na? You are going for exam, FMG. Yes, I agree. All question you know very well, but something this you need to remember. Answer. Marker of neural tube defect in amniotic fluid. If this is increased, we suspect neural tube defect. What? Marker of neural tube defect. Acetylcholine esterase. Yes, Yusuf. Akshit. Himanshu is acetylcholine esterase. Some key MCQs on neural tube defect. Biochemical marker used for antenatal screening of neural tube defect. Acetylcholine esterase, alpha fetoprotein. Acetylcholine esterase is most specific. Now, effective way to prevent neural tube defect such as meningomyelocele is to administration of folic acid need to begin. Folic acid need to begin when first baby is a neural tube defect. Now couple is planning second pregnancy, they consult you, doctor, we don't want our second baby is having neural tube defect. What advice you give to mother? Start folic acid When, yes, 4 milligram, okay, 4000 microgram, okay, but when? Before conception. Tell the couple when they are planning pregnancy, mother should start taking folic acid 1 month prior to conception and continue it for 3 months of pregnancy. So folic acid need to start 1 month prior to conception. Dose of folic acid is 4 milligram. In which first baby is having neural tube defect. You want to prevent 1 month prior to conception. Most common cause of congenital hydrocephalus. I want answer from your side. Most common cause of congenital hydrocephalus. Come on, give me the answer. Most common cause of congenital hydrocephalus. Rachna, Devini, Himanshu, Akshay, where is Yusuf? Yes. Answer. Most common cause of congenital hydrocephalus. It is equiductal stenosis. Equiductal stenosis. Very good, Shubham. Equiductal stenosis. So these few points about neural tube defect. Mother take which drug during pregnancy leads to neural tube defect in the baby? It is sodium valproate. Last to last year FMG question. Answer this question. All of the following have proximal muscle weakness. Any muscle disease, whether it is myopathy or it is dystrophy or it is dermatomyositis. Muscle means proximal muscle weakness. Only one muscle disease having distal muscle weakness, and that is myotonic muscular dystrophy. So remember this. Myotonic muscular dystrophy. Myotonic muscular dystrophy is the only muscle disease which not have proximal muscle weakness. It is having distal muscle weakness. Very good. Remember, move fast. Answer this question. Easy one. I expect everyone should know this question. 10-year-old male present with recurrent gross hematuria, poor vision due to cataract, poor hearing due to sensorineural hearing loss. Mother's brother required a renal transplant. It is X-linked recessive or X-linked dominant condition. Yes, triad of hematuria, cataract, sensorineural deafness. It is Alport. This question comes in every exam. FMG, NEET, PG, INI, CET every 3 years. Same question, same sequences, same choices. This is Alport syndrome. Alport syndrome. Now see. Hemolytic uremic syndrome. HUS is a triad of. Hemolytic uremic syndrome is a triad of ATM, A for acute renal failure. Which collagen? Collagen 4 and 5. Pooja, collagen 4 and 5. Yes. ATM, acute renal failure, thrombocytopenia, microangiopathic hemolytic anemia. It occurs after an attack of dysentery. Child having loose motion in which blood comes. And after 3-4 days, child comes to you with puffiness of eyes, pallor, petechial spots over body. When you examine, hemoglobin 9, platelet 20,000, urea 100, creatinine 4. Child is in acute renal failure, platelet low, microangiopathic hemolytic anemia. Attack occur after a dysentery. This is hemolytic uremic syndrome. It's a triad of ATM. What is TTP? thrombotic thrombocytopenic purpura. It's a pentad of ATM we can add plus CNS and plus fever. See, ATM is there plus fever and CNS involvement. So remember these points. Alport you remember, hemolytic uremic syndrome you need to remember, thrombotic thrombocytopenic purpura TTP you need to remember. Full questions all are the feature of hemolytic uremic syndrome except D choice is always CNS involvement. No, CNS involvement is a feature of TTP. Clear? Yeah, answer this question. In my learning days, I always confuse between HUS and HSP, but you are not because you are intelligent. So remember, read this question. 6-year-old boy, purpuric petechial rash all over buttocks and lower extremity. This is the rash. If you see once this rash, you will never forget the picture. Below buttocks. Child is well, afebrile, but a swelling of right knee. Arthritis is also there. CBC is normal. It's a purpuric rash. CBC normal means platelet counts are normal. Which of the following is most likely diagnosis? By looking at the rash. This is Hinox colon purpura, HSP. HSP, you have 4 points. Number 1, rash. Number 2, arthritis. Number 3, pain, abdomen. Number 4, glomerulonephritis. Rash is present in 100% of the patient. Yes, Yusuf. You can't make the diagnosis of HSP without rash. Arthritis present in 80%, pain abdomen in 60%, glomerulonephritis in 50%, but rash in every patient. In our question, rash and arthritis is there. So answer would be HSP, Hinox colon purpura. Hinox colon purpura. Arthritis in 80%. Friend, clear? Clear? So HSP, HUS, TTP, Alport. These are clear. IgA nephropathy, post-streptococcal nephritis. These are the key questions from the nephrology. Absence seizures, neurology. We will cover some more question, neurology. Acyanotic CHD, types of murmur, cyanotic CHD, TAPVC, tricuspid atresia. पिक्चर अभी बाकी है मेरे दोस्त. Continue. Strength of glucose in hypoosmolar ORS. Oh ho. I remember this, but I always forget. It's not acceptable at this time of exam. Sodium, potassium, chloride, citrate, glucose, osmolarity. You need to remember. Sodium 75, same is the glucose 75. Potassium 20, chloride 65, citrate 10, osmolarity 245. So glucose in hypoosmolar ORS is 75. 75. Suppose in your exam, question come, what is the osmolarity of hypoosmolar ORS? 245. These questions you need to remember every time. It's not we don't revise pediatrics in last 1 month. So what? So what? Remember this, always hypoosmolar ORS, always. This is the strength. Clear? Hold on, 15 seconds. Remember it, finish it off now. Sodium 75, potassium 20, chloride 65, citrate 10, glucose 75, osmolarity 245. Finish it off. Answer this question. Little bit maths, I give you 30 second, 45 second, 60 second. Okay, answer this. 1 year, male child, weighing 8 kg, presented with loose motion. On assessment, sign of some dehydration were present. Some dehydration. Pooja, don't jump. 8 kg weight, signs of some dehydration. So what are the signs of some dehydration? Child is thirsty and child is irritable. Thirsty means child will take ORS. If we write here severe dehydration, so what is the sign of severe dehydration? Not accept orally and child is done. When some dehydration, we use plan B. When severe dehydration, we use plan C. So what is plan B in treatment of diarrhea? Plan B is weight into 75 ml ORS in 4 hours. So what is the weight? 8 kg into 75 ml ORS. It is 600 ml ORS in 4 hours. Pragya, you are right, but I want correct answers. Multiply, na? No. We are biology students. No, multiply 8 into 75. So you can't miss this type of question. Yesterday we covered marasmus and kwashiorkor. Today is diarrhea. This is diarrhea. When a child comes for diarrhea, first thing we need to assess the degree of dehydration. In this, examiner was very kind to you. He answered child is in some dehydration. Sometime examiner asks child is very irritable but drink whatever you offer to the child. So it's irritable, thirsty, some dehydration. Lethargic, not able to drink, severe dehydration. Just remember these 4 points. These are the key. Rest all will help in the diagnosis. Skin pinch, dryness of mouth, eyeball, help. But these two are the key. Whether child is some or severe dehydration. Mild, moderate dehydration word not used any long. Clear? 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 So when some dehydration, we use plan B. Severe dehydration, we use plan C. What is plan B? Plan B is weight into 75 ml ORS in 4 hours. Yeah, Pragya Singh, I miss it. You put it on the top 600. Very good. My apology. Okay. Okay. Answer this question. 18-month white boy manifest failure to thrive, poor appetite, abdomen distension, diarrhea, irritability. But okay. But next, had been well until 9 months of age. What is this? This child is very well till 9 months of age. Weaned from breast milk to the regular foods, his growth curve is flattened. Now see, you will try to understand why pediatricians are so meticulous in their work. They always take the weight of the child, put the weight on the growth charts. Why? Why? This is the logic. Suppose birth, 3 month, 6 month, 9 month, 12 month, 15 month, 18 month. So this is the birth weight. Then growth chart shows 3 month, 6 month, 9 month. Good weight gain is there. Till now, everything is fine. Everything is fine. But here, what growth chart tell you? Flatten. The weight at 9 month is 9 kg and weight at 18 month is also 9 kg. This is clinch in the diagnosis. Growth curve is flattening. Growth curve is flattening. Till 9 month child is well. 9 month what you add? Regular food. we introduce wheat cerelac in the diet. Wheat means it is classical of celiac disease. Growth curve flattening. 9-month child is well. When you wean the child from breast milk to regular food, then no growth, abdomen distension, diarrhea. It is celiac disease. Celiac disease. Am I clear? Am I clear? Which HLA associated with celiac disease? HLA DQ2, DQ8. This is asked one time. Celiac disease, gluten sensitivity. Child not respond to gluten diet because we need to avoid gluten from the diet. So we do the blood test, TTG, HLA and biopsy. Okay, proven. We remove the wheat from the diet. Follow this child, start gaining weight again once you remove the wheat from the diet. DQ 2 and 8. DQ 2 and 8. Shubham, very good. Answer this question. I am waiting. Who can answer this question? चावल देंगे. Very good. But wheat नहीं देंगे. गेहूं नहीं देंगे. Okay. Which of the following is the marker for intestinal inflammation? Very good, Yogesh. So you all are intelligent. You all are intelligent. Good, 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 good. Now see. Child presenting with chronic or recurrent diarrhea, initial workup include stool culture and antibody test for parasite. Stool microscopic for ova and parasites. Basic test, stool culture and stool protein microscopic. Fecal leukocytes, calprotectin and lactoferrin, inflammatory disorder. To exclude inflammatory, so they are present in inflammatory disorders. Stool pH, a reducing substance for carbohydrate malabsorption. Lactose intolerance. Stool pH will be less than 6 and stool reducing substance present in the stool. Stool osmolarity to differentiate between secretory and osmotic diarrhea. Fat examination demonstrate fat malabsorption. Alpha 1 antitrypsin for protein malabsorption. And for pancreatic insufficiency, elastase 1. Elastase 1. So remember, these two are very important. Last year, they asked this question. Intestinal inflammation. You all got it right. Calprotectin or lactoferrin. This time they ask alpha-1 antitrypsin for protein malabsorption. Stool elastase for pancreatic insufficiency. So clear? Clear. Which of the following marker, ovocyst culture we do to diagnose parasites, all those things, infection. But these are the things you need to remember. Croup. What is croup? Acute laryngotracheal bronchitis caused by para influenza virus. Give me just 5 minutes. All the question on croup and epiglottitis, exam question and clinical background, everything will be clear to you. 5 minutes. Start the stopwatch. Acute LTB, croup caused by para-influenza virus. There is a history of URI. Running nose, mild cough. Running nose, mild cough. for 2 to 3 days. Mother will tell you, yes, my child is having running nose, cough last 2 3 days. Then signs of respiratory obstruction develop. There is a classical history of URI for 2 to 3 days. Then signs of respiratory obstruction develop. What are the signs? See, hoarse voice, barking cough, inspiratory stridor, increased breathing, larynx, hoarse voice, trachea, barking cough, bronchials, inspiratory stridor. That's why laryngotracheal bronchitis. First, there is a URI for 2 to 3 days. Then child develop all these features. Clear? Classical history will be there. X-ray show stipple sign. See, X-ray show stipple sign. What is stipple? Top of the church. Like this. Airway. Classical X-ray. Last year FMG question. They give this X-ray. Stipple sign. Okay. Now, what is the treatment? Classical. Cough in the group na barking cough. Ooh. Strider. Child comes like this. You can't miss in the emergency. Child with croup. Croup diagnosis is there. X-ray shows stipple sign. What is the treatment? Nebulize with epinephrine plus oral steroid. No role of antibiotics. No role of antibiotic. Nebulize with epinephrine and give oral steroid. Clear? Croup. What is epiglottitis? It is acute fulminant condition. Acute fulminant condition. Most common caused by H. influenza. You can argue me. Now it's not H. influenza, streptococcal pneumonia, but yes, book says H. influenza is the commonest cause. But what happened? Start with fever and sore throat. Within 6 hours, child parents are leaving for their job. Child at home, 2-year-old child with caretaker. Child have mild fever and sore throat, but parents has to go. What happened in next 6 hours? They receive a call from the hospital. Child is very sick. What happened in this 6 hours? Signs of respiratory obstruction develop. Toxic look. Drooling of saliva. Dysphagia. These all are the signs. Nirmala, keep positive thought this time. No negative thought. हम पास होंगे, जरूर होंगे, क्यों नहीं होंगे? Just positive thought. Try your level best. God is there. Okay. So within 6 hours, you find child bend forward. Air hunger is there. Tripod position. Drooling of saliva. Very toxic look. Parents are telling child is very well in the morning. Epiglottitis, acute fulminating course. Even in the best center of world, mortality with epiglottitis is 10%. Because it's rapidly progress and it not give you time to reach to the hospital. And if you reach, proper treatment. See, diagnosis. How you diagnose it? Very good. Sonu Sharma. Yusuf, now you read my brain actually. You are answering the questions which I supposed to ask. Diagnosis. Diagnosis by direct laryngoscopy. Child comes in the emergency, toxic loop, drooling of saliva. You feel this child is going to die. So what you will do? First, you try to establish the airway. You need to put the endotracheal tube. As soon as you do the laryngoscopy, this is the picture. Oh my God. This is normal epiglottis. And this is cherry red epiglottis. You will never forget. Now, as soon as you do the laryngoscopy, now another challenge. Put ET tube. My friend, normal you put ET tube here. Larynx is there. But here are you able to see the larynx? That's why. That's why. The problem, it's difficult intubation. If you are new one, you struggle in the intubation. So once you diagnose its epiglottitis, cherry red color epiglottis, hold on. Call your senior who is very well in intubation, because this child is not give you much time. First line of management, establish the airway. X-ray, if that child reaches to you by 3 hours with drooling, little bit drooling, dysphagia, fever, toxic look, but 3-4 hours, you can still send the child for X-ray, and X-ray you find thumb sign. So, stipple sign, croup. Thumb sign, epiglottitis. But diagnosed by direct laryngoscopy. Now come the treatment. Sitting with neck extend, because air hunger is there. Because of epiglottitis, epiglottis is inflamed, swollen. Child is not able to take air, air hunger. Sit forward, tripod position, neck extend. This is the posture in. This is the posture in neck extend. See, it's not flex, extend. Bend forward with extended neck. Treatment. First line of treatment. Establish airways. Establish airway. Intubation. If this is not given in the choice, then start antibiotics. No role of steroid or nebulization, because you need to hit H. influenzae or pneumococcal. Generally in Western world, they are very particular about antibiotics. They not start antibiotic very frequently until unless culture is positive. But this is the scenario. You can't wait for culture. Intubate the child, start high antibiotic, ceftriaxone, meropenem. Send the culture later on, but you need to hit the bud as early as possible. If you intubate the child, start antibiotic, same child coming in front of you after 4 days running, because antibiotic hit, you intubate the child, 2-3 days, edema subside, child extubate, then everything is fine. This is the treatment. Now read the question. Read question sincerely. Try to make an answer. Two-year-old son developed noisy breathing on inspiration, marked retraction of chest wall, flaring of nostril, barking cough. Mild upper respiratory infection for 2 days. Which therapy is indicated? It's croup, inhaled epinephrine, and a dose of steroid. Clear, na? When you know the topic, na, every point in history is looking, yahi hoga. Got my point? Got my point? You know the topic well. You know the topic well. Answer this question. 6-year-old fully immunized, brought to the emergency room within 3 hours. Fever high grade, sore throat, child appear alert, anxious and toxic. Mild stridor, drooling, no barking cough, no barking cough. Child is not able to cough. He is sitting on the examination table, leaning forward with neck extended. Lateral radiograph. It's a thumb sign. What you do? Prepare to establish an airway in operating room or ICU. First thing, intubate. No role of culture, no role of IV line. Why you want to waste time in IV line? Child will cry, cry, cry. Edema will increase. No role of epinephrine nebulization. Just establish an airway. Establish an airway. Okay. Croup clear. Epiglottitis clear. Diarrhea, celiac disease, ORS clear. Cyanotic, acyanotic CHD. Classical question on nephrology. Absent seizure. Something more. Answer this. Neurodevelopmental regression, epileptic spasm, and hips arrhythmia is a triad of West syndrome. After intubation, put the child on ventilator. Do not prick here and there, just a single prick. Take the culture and start antibiotic. That's all. Wait, antibiotic will act, edema will subside, then accordingly you extubate the child in a 2 days or 3 days. Clear? Travel with Chandan. Okay, this is a triad of West syndrome. What is Landau-Kleffner syndrome? Seizure disorder. Seizure plus sudden onset aphasia. There is a classical history. Classical. Child have multiple seizures. Parents come, okay, we given some medication at local place, 2 medication to control the seizure. Doctor, seizures are not there, but our child is not able to speak a single word in last 36 hours. Seizure with sudden onset aphasia. Sudden onset aphasia. It's Landau-Kleffner syndrome. Seizure with sudden onset aphasia is Landau-Kleffner syndrome. Clear? Clear? West syndrome, neurodevelopmental regression, epileptic spasm, hips arrhythmia. This question was there in NEET and FMG both. This is West syndrome. West syndrome. Answer this question. I am holding. Let's see who can answer. A 4-year-old child, profuse bleeding due to fall on the road. Now listen. If child having bleeding from skin or mucous membrane, or child having bleed on joint or muscle, these have 2 different implications. If child have skin bleed in the form of petechiae spots, mucous bleed, epistaxis, menorrhagia, GI bleed, child is having platelet disorder. If child fall on the road having bleed in the joint or during IM injection, bleed in the muscle, child have clotting factor disorder. In our patient, fall on the road, bleeding occur from the joint, sometime inside joint, sometime outside joint, bleeding occur. What is our approach? Our approach is very simple. We need to do PT and APTT. If PT is increased, this is factor 7th deficiency. If APTTs increase, you are dealing with either 8, 9, 11 or 12 deficiency. 8 means hemophilia A, 9 means hemophilia B, 11 means hemophilia C. It's very simple. Sometime accidentally once in a 6 month patient posted for surgery, APTT come more than 200. Then we come to know patient is hemophilia. If APTT prolong, 8, 9, 11, 12. If PT prolong, 7th factor deficiency. If both prolong, PT and APTT both prolong, 2, 5, 10. 2, 5, 10. And late vitamin K deficiency. Now listen carefully. PT and APTT slightly prolonged, but main culprit is TT. Thrombin time is prolonged. Thrombin time is prolonged. Then it is disorder of fibrinogen. Either afibrogeniemia or dysfibrogeniemia. TT prolonged, afibrogeniemia or dysfibrogeniemia. Now listen, if all are prolonged, then it is DIC. PT, APTT, TT, bleeding time, clotting time, everything is deranged. DIC. Now listen carefully. All normal. PT normal, APTT normal, TT normal, all normal. Platelet count normal, bleeding time normal, everything is normal. But bleed continue. What is this? What is this? It is factor 13th deficiency, which is diagnosed by urea clot lysis test. Urea clot lysis test. Now see, in this question, normal platelets, PT and APTT slightly high, associated with high TT. Thrombin time is high. Thrombin time is high. So what is this? Afibrogeniemia. Suppose question comes, every test is normal, but bleed continue. So which factor deficiency is there? There is a deficiency of 13 factor. How you diagnose this? By doing urea clot lysis test. Am I clear? How to know hemophilia A, B and C? Very simple question. You need to, one APTT is prolonged, then you need to check factor 8 level, factor 9 level, factor 11 level. Which level is low? That hemophilia is there. Clear? Pooja? Clear? So this is the thing. I go little fast, no problem. I can write again for you. Let's see. Now concentrate. Someone feel I've been going fast, but I need to teach you more and more thing. If PT prolong, factor 7 deficiency. APTT prolong, 8, 9, 11, 12 deficiency. A, B and C hemophilia. Both are prolonged, 2, 5 and 10 deficiency. PT and APTT slightly prolonged, but main culprit is TT. Afibrogeniemia, dysfibrogeniemia. All are prolonged, it's DIC. All are normal, but bleed continue, it's factor 13th deficiency, which is diagnosed by urea clot lysis test. Answer this question. I bet you will definitely get one question either from clotting or platelet disorder. Clotting is over. Now come to platelet disorder. Answer this question. Read carefully. Read carefully. I am waiting for you. Read carefully. How to differentiate between afibrogeniemia and dysfibrogeniemia? Check the fibrinogen level. If fibrinogen is low or absent, it's afibrogeniemia. But fibrinogen level is normal, but malfunction is there, dysfibrogeniemia. You need to check the fibrinogen level. A 4-year-old girl referred for evaluation of possible inherited bleeding disorder. History of easy bruising, skin bleed, frequent nosebleed, mucus bleed, resulting in anemia. Platelet count and platelet morphology on smear are normal. It's normal. But history suggests it's a platelet disorder. What is in history which suggests it's a platelet disorder? Skin bleed and mucus bleed, nosebleed and bruising. Okay, you do the bleeding time, it's prolonged. Stamp, it's a platelet disorder. Check the platelet counts. They are low, it's quantitative disorder of platelets. But in our question, platelet counts normal. Platelet count normal, then it has to be platelet function abnormal. Platelet qualitative disorder. Platelet count is normal, but their functions are abnormal. What are the disorder? Bernard-Schuler syndrome. Bernard D is there. It's a disorder of adhesion. Glengemann thrombasthenia. Glenge G. It's a disorder of platelet aggregation. Ray. It's a disorder of platelet release. Bernard-Schuler syndrome, Glengemann thrombasthenia, Gray platelet syndrome. Now listen, in Bernard-Schuler syndrome, there is huge, giant or mega platelets. Here, Glengemann thrombasthenia, platelet morphology normal. In Gray platelet syndrome, you find gray platelet in PBF. In our question, platelet count normal and morphology is also normal, but it's a platelet disorder. Platelet count normal, but their function is abnormal. Which function abnormal? Adhesion, aggregation, or release? We try to find out by platelet aggregation study. In this, we look for platelet aggregation study revealed abnormal response to ristocetin. It is Bernard-Schuler syndrome. Platelet aggregation study revealed abnormal response to ADP, collagen, or epinephrine. It is Glengemann thrombasthenia. Come to the question. Platelet function study shows absence of aggregation to ADP, ADP, epinephrine and collagen, but normal response to ristocetin. So your diagnosis is Glengemann thrombasthenia. Same question, I change one line. Platelets are giant and platelet shows abnormal response to ristocetin. Then answer would be Bernard-Schuler syndrome. Am I clear in platelet functional disorder and clotting factor disorder? If no, put repeat, sir. Please repeat. I will again repeat. But it's very simple. I agree. I go little fast. But this is the need of the hour. We need to cover more and more topic with limited times. So clear na? Platelet functional disorder, clotting factor disorder. These all questions are waiting for you, my friend. Clear? Von Willebrand disease, I will teach you. See, von Willebrand disease always behave APTT is prolonged because von Willebrand factor always attach with factor 8. In von Willebrand disease, APTT is prolonged. APTT is prolonged. PT normal, APTT is prolonged only in von Willebrand disease. Clear? Because von Willebrand factor always attach with factor 8. In von Willebrand deficiency, factor 8 function is abnormal. So what it reflect? Increased APTT. Answer. थोड़ा लाइट हो जाए, थोड़ा सिंपल क्वेश्चन. Which of the following is most appropriate method to obtain a urine specimen for culture in a 9-month-old girl? 9-month-old girl. Yes, when we make the diagnosis of UTI, we always do urine culture. 3 methods you can obtain urine culture: by put a catheter, or you can collect urine by midstream. Tell the child, void the urine. In midstream, you put the container and collect the urine, and you can do by suprapubic aspiration. Feel the pubic symphysis. Put your needle down, aspirate it, urine will come. So how much organism grown in that urine will tell you it's UTI, yes or no. Here is the guideline. If you collect urine from midstream clean catch sample, 10 to the power 5 colony forming units indicate it's UTI. If you collect urine by a catheterization, then 5 into 10 to the power 4 colony forming unit indicate it's UTI. But if you collect urine from suprapubic aspiration, a single colony forming unit, even one colony forming unit, any number of pathogen, one colony forming unit indicate it's UTI. So the most appropriate method in a 9-month-old girl, in an infant, it is suprapubic aspiration. You can't do suprapubic aspiration in 4-year-old boy. He can't allow prick. Okay, so at that the boy is intelligent enough. Mother tell, okay, you urinate, I will collect in the container. It's okay. But infant, it's difficult to collect the sample. That time the most appropriate method, suprapubic aspiration. One question come like this: if urine collect from suprapubic aspiration, when we called its UTI, when single organism detected, when 10 to the power 2, 10 to the power 4, 10 to the power 5. Single organism detected in suprapubic aspiration, it's UTI. It's UTI. Clear? In infant, the most appropriate method, suprapubic aspiration. Clear? Clear? Answer this question. So, a girl or boy, fever and convulsion, we think it's a febrile seizure or it's meningitis. But 10 year is not the age of febrile seizure. So we think it's a meningitis. It may be bacterial, it may be viral, it may be tubercular, but it is meningitis. How? Answer will come from lumbar puncture. Answer will come from lumbar puncture. See, this is the lumbar puncture. You do the lumbar puncture in a girl who present with seizures and fever. Cell counts less than 5, all lymphocytes. Protein 20 to 40 milligram percent. Glucose, CSF glucose, 2/3 of blood sugar. If blood sugar is 100, CSF sugar is 66. It is normal. Second scenario, you collect the CSF, cell counts are 10 to 10,000. All are neutrophils. Protein definitely increase and sugar markedly low, less than 1/3 of blood sugar. Blood sugar 100, CSF sugar less than 33. Another scenario. Cells are 10 to 10,000, but all lymphocytes. Biochemistry normal, protein normal, sugar normal. Cells lymphocytes, it has to be viral. It has to be viral. Fourth scenario. Cells lymphocytes. Look at the biochemistry. Protein increase, sugar low. Means cells neutrophil, it is pyomeningitis. Check, CSF sugar is also low. But cell lymphocytes, check sugar and protein. If they are normal, it's viral. If they are also change, it's tubercular. क्वेश्चन अभी बाकी है मेरे दोस्त. CSF examination revealed protein 200 increase, sugar 40 low, but cell counts 100, all are lymphocytes. When all lymphocytes, pyo is out. Now we have to distinguish tubercular or viral. But biochemistry change, it has to be tubercular. But my question to you, which was asked in FMGE, tubercular meningitis, anything by grossly looking at CSF, you can tell it's tubercular meningitis. Come on. We always collect CSF in our MD days. Our madam told us, collect CSF in 2 test tube. First test tube, go for lab. Another test tube, bedside of the patient. Yes, cobweb. When the madam come for the round in the morning, she always see the test tube. So here you find, if it's a tubercular, you find something is hanging like this. Cobweb. This was the MCQ in FMG. Cobweb in tubercular meningitis. In tubercular meningitis. So these are the must know MCQs. I prepare these with my experience and I will not disappoint you. Answer this. Answer this. 2-year-old child present with facial nevus on left side. Okay, this is left side. This is right side. Facial nevus on left side. Glaucoma is also on left eye. Opposite side paralysis. राइट में पैरालिसिस होगा एंड राइट में ही कन्वर्जन आएंगे. अपोजिट साइड. सो लेफ्ट साइड नेवियस, right side conversion is right. Left nevus, left glaucoma is right. It show intracranial calcification is true. Paralysis occur opposite side of nevus. So left side nevus, paralysis can't be on left side. So A will be wrong. Yes, my friend, this is Sturge-Weber syndrome. Sturge-Weber syndrome. This is the commonest image in all book, in all grand test, at any platform. When image based question start coming in the exam, first in the NEET PG, this was in every exam. Sturge-Weber syndrome. Sturge-Weber syndrome. Clear? Beautiful question. Answer this question. Answer this question. Last year FMG question. I want answer from your side. Travel, Akshit, Kamal, Pragya, Yusuf, Dhavni, Pooja. Answer it. See. S1, S2, S1, S1, S2, S1, S1, S2, S1. So if murmur is there between S1 and S2, it is systolic murmur. Murmur between S2 and S1, it is diastolic murmur. Murmur start in systole, overlap the second heart sound, spill into diastole. It is continuous murmur. So our question suggests this murmur is systolic murmur. Clear na? Systolic murmur. Now see. Systolic murmur is of 4 types. S1, S2, S1, S2, S1, S2, S1, S2. First, I will draw all four type of murmur. And you will feel by right image, you can feel what is the difference. Clear? This is pan-systolic. This is ejection systolic. This is early systolic. This is late systolic. Pan-systolic murmur, only three cause in universe. Whether you are reading in MBBS or you are doing MD or you are doing your D and DM in cardiology. Pan-systolic murmur, MR, TR and VST. Ejection systolic. Pan-systolic murmur start at S1, overlap the sec S2. Ejection systolic murmur start a gap from S1 and end at S2. Crescendo, decrescendo murmur. Aortic stenosis, pulmonary stenosis. Early systolic, tiny VST. And late systolic, classical HOCM and MVP. In our question, murmur is pan-systolic. Murmur is pan-systolic. Now you can answer pan-systolic murmur present in mitral regurgitation. Clear, na? Clear? A is the answer. Last year FMG question. If any doubt, clear your concept in this. Clear your concept in this. I will not tell. 30 seconds for you. I want correct answer, my friend. Try. Don't hesitate to put answer. Please, please, please answer this. Murmur between S1 and S2. So it has to be systolic murmur. Which systolic murmur is this? It is not pan-systolic. It is not pan-systolic. It starts from gap from S1, crescendo, decrescendo. Crescendo, decrescendo. So it's systolic. So MS is out, in which diastolic murmur is there. VSD is pan-systolic. MR is also pan-systolic. So these are also out. This is ejection systolic murmur present in aortic stenosis. Why so many less answers are there? Why? Am I clear, na? Two question, classical question from the previous year paper. Identify the murmur. This may come. Answer this. Now they know you have some clinical knowledge also, because people FMG have good exposure sometime, the clinical practice. At least they should know, you know this. This is MDI, meter dose inhaler. When you push here, mouth is here. After removing the lid, so it require push and breath coordination. You push, press and breath coordination. Yes, a child can't do this. So MDI is the device of choice when child age is more than 12 years. Clear? What else? This is MDI. This is MDI with spacer. This is MDI with spacer with mask. When child is more than 12-year age, he or she can use MDI because he know press, take breath, press, take breath. When child is not able to coordinate, so we use spacer. When we press, particles is here. which child can take with subsequent breath. But child is intelligent enough to hold that piece in mouth. So this is the instrument of choice between 4 to 12 year. But child is 2 year, 1.5 year, he can't able to put it mouth. Then we use the mask. It is the below 4 year. Clear, na? Children below 4 year. MDI with spacer with mask. Children 4 to 12 year. MDI with spacer. And children more than 12 year, it is MDI. Clear? Say yes. Image based question. This device used in the children above 12 years. MDI, meter dose inhaler, which require push and breath coordination. Images. Chest X-ray in CHD. All are classical. I bet you every X-ray was asked previously in exams. This is grossly box shaped heart. This is egg on side appearance. This is figure of 8 or snowman appearance. It is boot shaped heart. Remember this in your brain. Chest X-ray in CHD. Box shaped heart present in Epstein's anomaly. Egg on site present in TG. Snowman or figure of 8 2 times asked in previous 4 year in exam. TAPVC. Boot shaped heart present in top. You find ECG, you find murmur, you find chest X-ray in CHD, you find X-ray of steeple sign, you find thumb appearance. So these all are classical devices used in asthma treatment, Sturge-Weber syndrome. So I try to cover most classical question from systemic pediatrics. Our limitation 1.5 hour to ensure you 150 question in your exams. So I try my level best. All educators who are on this mission for you people, FMG mission, okay, Unacademy platform, read it, believe it, trust the God, trust yourself. This is pediatrics for you. Pediatrics 1, in which we cover basic pediatrics, neonatology, growth development, vaccine, syndromes, metabolic disorder yesterday. If you miss, watch it again. Today we cover systemic pediatrics and I am with you, Dr. Sanjay Khatri, pediatric educator on Unacademy. This will help you, my friend. This will help you. I try my level best to put your morale on the higher side. This is the basic difference. Feel positive. Do it. Do it. Put your maximum effort. My blessings, my prayers are with you. Keep reading. Keep reading. Let's crack it. Let's crack it. Thank you. Bye bye. Hope to see you all success in the exam. Once exam over, share the questions with me on my Telegram group. We will discuss and hoping for the best results as per your capacity. Thank you. Bye bye. God bless you all. God bless you all. When will you come again? When you call. If you want more classes, I will come again. But this is pediatrics is sufficient. These 2 sessions. If you want more, I will give you more classes. Discuss with the team. But I think this is the pediatrics for you. I put my all experience in these 2 sessions to give you best of the question for FMG. Thank you. Bye bye. God bless you all. My prayer, my wishes all are with you. Thank you.